warm welcome to the second day of the 8th World Congress of the World Association of Laparoscopic Surgeons 2025. We apologize for a little delay. We will be beginning with the first session for today, which is on paper presentation. May I take the honor to invite our chairpersons, Dr. J.S. Chauhan, Dr. Rakesh Durkure, Dr. Krishna Nandan Kumar, Dr. Shailesh Kumar, to please be on the dais for chairing this session. I would also like to invite the first speaker, Dr. Nabil Nazir, if you're there in the hall. Dr. Nabil Nazir. Okay, so we'll take a minute more. Dr. Nabil will be here in a minute, sir.
Hello, good morning everyone. So my name is Dr. Nabil Nazir. I head the Department of Minimal Access and GI Surgery in Mehta Hospital, which is one of the oldest private institutes in Chennai. So my topic for today is randomized controlled trial between single incision versus single site multi-incision appendicectomy. So as you all know, appendix is like an unexpected guest at a party. You really don't know what it does. But then when it gets angry and inflamed, it becomes a party crasher and it has to be removed. So in the present scenario, the gold standard for removing appendix is a laparoscopic appendicectomy. The reasons are reduced postoperative pain, shorter hospital stays, and better cosmetic outcomes. But as human beings, as doctors, and as patients demand, we want more. From open surgery, we went to laparoscopy, and from laparoscopy, they want even smaller incisions so that there is better post-operative outcome. But single incision multi-port surgery was developed to reduce the number of incisions. But the problem we faced with such surgeries is, number one, is the limited maneuverability and technical difficulty to do the surgery. An alternate approach, which is a single site multi-port, gave us better opportunity to remove the appendix with better cosmetic outcomes and more flexibility. So all these laparoscopic single site surgeries are pushed even by the market as well as by the surgeons who want to push their boundaries. But still, it is still not clear, and there's no much data that shows which is better over which. So my study design was for the last 6 months, 3 surgeons, myself, Dr. J.S. Rajkumar and Dr. Anirudh, we had a set of 50 patients, and both were selected based on the slip and pick method, where the patients were given chits and they had to take up the chit, and then depending on that we operated on them. So 23 patients underwent single incision multi-port surgery and 25 patients underwent single site multi-port surgery. The inclusion criteria were people between the age of 18 to 16, diagnosed on CT abdomen acute appendicitis, and no prior history of any abdominal surgeries. The exclusion criteria were anyone above the BMI of 35, patients with diffuse peritonitis or appendicular mass, and patients who had significant comorbidities. So we had to convert from single incision surgery to laparoscopic surgery for 2 patients who had peritonitis and one had intraperitoneal bleed. So this is how we do the single incision multi-port. So you put a transverse incision along the lower umbilical ridge and then raise a flap, put one 10 mm port in the middle and 2 5 mm ports in the side for holding the appendix and dissecting the mesoappendix. This is a single site multi-port incision where basically it's a radial spoke incision. You have one incision at the supraumbilical ridge, one incision in the infraumbilical ridge, and one incision in the lateral umbilical ridge. So all the 3 ports are within the umbilicus. We can do it as a 2-port surgery or a 3-port surgery. If you do it as a 2-port surgery, you have to use a mini alligator, which is a 2 or 3 mm port in the right iliac fossa, which helps to retract the appendix. So both the procedures were obviously done under general anesthesia, and the same steps were followed for both. Post-operative pain was based on the visual pain score. So obviously a statistical analysis was done by the SPSS version 20. So the pain scores, so what we found is the pain scores for a single incision multiport and a single site multiport incision, the pain score after 12 hours was almost exactly the same. There is no much difference in the p-value. But the pain outcome after 24 hours, what we noticed is in the single site multi-incision appendicectomy, we felt that there was a drastic decrease in the pain of the patients who had underwent this surgery. Now, cosmetic outcomes, our patients felt that, after 1 week of surgery, the patient's perspective is, both the side of the patients, they felt very happy with the incision. But when it came to the surgeon's part, obviously this is biased because every surgeon, they feel that what surgery they do is the best. So on the surgeon's perspective, what we found is the single incision multiport is which is having a better post-operative scar, and we were happy with the single incision multiport surgery. In the technical ease, obviously because of the multiple incision in the supraumbilical and the infraumbilical region, we felt the maneuverability and the flexibility was easier in a single site multi-incision surgery. Operating time was nevertheless almost the same, so no big difference between the operating times. And like I told you, 2 patients we had to convert to laparoscopic surgery. Post-operative pain was exactly the same after 12 hours. 24 hours is where we saw better post-operative pain for the patient. Technical ease was better in a single site multi-incision surgery. So this, I have a small video where, so this is how, since what our study found was a single site multi-incision surgery is where you have better post-operative outcome, better post-operative pain. So I put a video of how we do the single incision, single site multiport surgery. So what we do is we infiltrate local in the supraumbilical ridge in such a way that the supraumbilical ridge is everted out. Then we hold it with the ALICE, and then we make a transverse incision just on the supraumbilical ridge. Since it is everted out, once the surgery is done and the effect of the local is gone, it tends to invert inside, so there is no scar post-operatively. So this is the first port, this is the camera port, and then in the lateral umbilical ridge is when we infiltrate it with local again, so that the ridge is everted out, and then we put our 5 mm port. So this is where I am putting an incision in the lateral umbilical ridge for my working port, and the working port is introduced in. So if I am doing a 2-port surgery, then I used a mini alligator on the right iliac fossa. If it is a 3-port surgery, the 3rd port is there in the infraumbilical ridge. And this is the scar. So if you can see the scarring, you can just see a small cut in the supraumbilical ridge. This is a single incision multiport surgery. And on the left, you can see that this is a single site multi-incision surgery. So conclusion of our study is a single site multi-incision surgery has better post-operative outcome and better cosmetic, better cosmetic for the patient. This is a small video that I have of the whole surgery, just a 1-minute video. I think this is my last slide. So this is the first port that is done in the supraumbilical ridge, and then you have in the lower umbilical ridge another 5 mm working port. And in this surgery I used a mini alligator. So if you can see a mini alligator through the right iliac fossa is where I am holding the appendix, and then from here on it's just the normal appendicectomy where you separate the mesoappendix, go up to the base, double loop it and take it out. Yes, so I think I'm done. Thank you. Thank you, sir.
Thank you, Dr. Najir. Thank you for your good presentation. Dr. Najir, can you make some remarks? Dr. Najir, how do you handle the ergonomics in the single incision multiport? There is always a problem with ergonomics.
Yes, ergonomics, when we are thought about laparoscopic surgery, it is always about the ergonomics, maintaining the azimuth angle, not clashing of the instruments. But then this goes totally against what we have thought initially in our career. But then for having a better post-operative scar, because people are now more cosmetically oriented, they want to have as less scar as possible. So in this also we are able to give the same treatment to the patient without compromising the patient's health. But it is obviously a technical difficulty for the surgeon and the assistant who is doing it, because basically we are clashing with each other and there's a lot of swording of the instruments also.
And what is your conversion rate in your study?
2 patients we had to convert to laparoscopic surgery, yes. Because of one was because of peritonitis that were inside, and second was because of the intraoperative. We had a small bleed from the appendicular artery which we could not control through single incision port.
Thank you.
What about the hernia recurrence?
Hernia recurrence, for now it's just 1.5 years of our study. Till now we have not got a hernia recurrence, but our 10 mm port is closed with J-vicryl. So we put 2 incisions and we close it.
Any comments or any questions from the audience? No. So now move on the next speaker.
Thank you.
Secondary speaker.